Good morning, everyone. Okay, today's live case transmission from Asan Medical Center. I'm very happy to have Dr. Spencer King here as a moderator and the many distinguished panel, David, Taggart, Sheiban, right, and Dr. Ashida, Dr. Oh, no, I'm sorry for that. Dr. Gwon Hyeon-Cheol, Deb Smith, and Dr. Masoumi, Dr. Nakamura, Dr. Okutsu, Dr. Santoso, Sheiban, again, Taggart, and Dr. Tessa, Dr. Tsuda. Thank you for joining us. So, Spencer, okay, anyways, we're going to open, right? Live case.
Okay, yes, it's great to be here again, and we're looking forward to these live cases. This morning's session was so fascinating. I'm just reminded that all these years I've been coming here and watching interventional cardiology develop in Asia and playing a small role as I have in it. It's just fascinating to me, but the one message I get is that I'm no longer the teacher. You're the teachers, and I'm now the student. And this is very clear to me, and I'm learning a lot. So I'm still learning, so this is good. So let's see what kind of cases we have today. First case is from Asan.
Okay, Dr. Han.
Yeah, good morning, it's
Okay,
Jay.
great. We can clearly see you all, and we have many distinguished faculty, distinguished panels here. So you want to start for?
Good morning, everybody. This is the third days of TCTAP 2023. I'd like to start the first live demonstration case. I'd like to introduce my team, Dr. Juyeon Kim from Korea University Hospital, and Young-Sun Park, our senior fellow. Dr. Park will introduce our first live demonstration case.
Hi, it's Young-Sun Park, and now I'm presenting the first case, live case. So a 58-year-old male was admitted for chest discomfort and for evaluation of abnormal SPEC. He has been treated for diabetes and underwent PCI at left main to proximal LAD and proximal left circumflex 1 year ago. The past medical history: he had no MI or coronary artery bypass surgery, and he had PCI 1 year ago at left main bifurcation site, and he has 2 stents in this lesion. Next, please. And he had diabetes, and he was ex-smoker, and the clinical presentation was stable angina. The baseline ECG, there's no, the normal sinus rhythm was detected, and there was no Q wave or ST change. The chest X-ray shows no cardiomegaly or no pulmonary edema. We have done non-invasive studies. The echocardiography shows normal LV systolic function without low motion abnormality, and treadmill test shows positive at stage 4. There's ST depression at V6 to V4 to V6, and the Thalium spec shows the reversible small size defect in the LAD territory and reversible large size defect in the left circumflex territory. Next, please. And baseline coronary angiography shows the RCA, there's no significant stenosis. And the LCA caudal view shows there's a ISR at the distal left main to the proximal LAD, and also severe stenosis at left circumflexus ostium. Next, please. And as well, we can see this distal left main ISR, two bifurcation site at cranial view and spider view as well. So we plan to target in ISR in left main bifurcation site with the OCT and IVUS.
Thank you, Dr. Park. So the audience panels or chairman, if you have any comment or question on this patient.
Very tough cases, right? Fluoroscopic calcifications, many ISL involved in the distal left main and proximity those. Very tight stenosis, circumflex. The circumflex ostium is not stented area, right?
Stented.
Yes,
Previously, we
Oh,
treated the
right,
left
there is
main
crushing,
bifurcation,
right.
yeah,
Okay.
using crush technique.
All right, it is very tough cases, and so, Sheiban, there's any?
Well, I think first thing to do is intravascular imaging in order to see whether is there a mechanical cause for in-stent stenosis in the circumflex, something like under expansion of the stent, or also I would evaluate the entity of bifunctional evolution of LAD because it doesn't seem that much.
I don't know if it can be possible, but it would be interesting. We've spent so much time talking about different techniques for dealing with the left main. It'd be interesting to know what the technique was here, how it was done, how this, I see stents in the left main, LAD, and the circumflex, but which technique was used originally?
Before that, David, personally, I think it is a really good candidate for surgery. I think so. All right. The reason why 58 young ages, already we got a stented, ISR, etc. And so, what do you think?
So thank you. Yeah, I think at times someone like me as a surgeon has a very simple view of life, and to me, even if this patient had not already been stented, I would have recommended at 58 years old, 2 mammary arteries, one to the LAD, one to the circumflex system.
Perfect.
Because we're looking for 20-year survival. So if this patient, even if they had not previously been stented, I would have recommended that first time. And when the patient comes back with in-stent restenosis, I would double recommend it.
All right. Anyway.
But back to my question, Dr. An, is it?
Yeah.
Can you tell us what the? This was a crush technique, or was it a provisional? And do we know the minimal lumen diameter of the left main? And
Of course. So,
might,
actually,
Yes, previous stent technique was the crush technique.
I completely agree with Imad that intravascular imaging is of utmost important to help elucidate the cause of this in-stent stenosis, whether this is mechanical, which had to be treated mechanically, or biological, like neoarteriosclerosis, or combination thereof. So in my hospital, usually I use IFOS, but we can also use OCT, because for in-stent stenosis with OCT, we can have a better visualization of the anatomy.
And one additional comment, perhaps. I think we would try, I agreed with David about both points, by the way, about surgery, and once you failed stents, surgery doubly. But assuming they're going to do this with percutaneous intervention, I would be trying really, really hard to avoid a second layer of stent anywhere. So very extensive predilatation, high-pressure predilatations as required, and eventually drug-coated balloons.
Can I check, is this patient have diabetes?
yes.
diabetes?
Yeah.
Yes.
Diabetes.
Ooh,
So
diabetes.
that triples the indication for surgery.
Right. Honestly, I asked Dr. An about, this case is send the patient to the surgery. However, nowadays,
Sure.
they cannot hear my opinions. So, Dr. An, so how would you do that? So what is your
So, yes, many panels suggest a very nice comment. So according to the panel's suggestion, before treatment, I would like to evaluate the intravascular imaging to determine what is the main cause of, what is the underlying mechanism of in-stent restenosis. So for academic purpose, we did the two intracoronary imaging. So the first, I'd like to show you the IVUS imaging.
Is it not too much difficulties to pass the wire, circumflex ostium?
No, no difficult.
Yeah, great.
This is a circumflex full back imaging. Yes, circumflex stent is the mid portion is very expanded. The neo-intima is very minimal. But here is the proximal portion of circumflex. Neo-intima packed the intralumen. Stent is not
Mainly soft plaque, right?
small. Yeah, it looks soft plaque. This is a very ostium of circumflex. Yeah, here is the left main. Shaft of left main is very nice. Stop. Could you show us the ostium
Osteoplaque.
over here? Yeah. 조금 더 밑에서 보여주세요.
Okay.
네, stop. Run, please. Here is the ostium of, stop. Here is the ostium of left circumflex. So the, compared with just below the ostium, at the ostial side, the stent is looks smaller than a distal portion. In addition, inside of a stent, there is a lot of neo-intima packed the lumen.
Okay, I want to just see, I just know, did you do the FFR for LAD part from?
No, I didn't do that. Yeah.
Alright.
So could you
maybe-
measure just the ostium of circumflex stent?
We always talk about this as unexpanded stent, but there's another mechanism here. It could be that the scar retraction, as the healing occurs, is squeezing the stent down in the proximal part.
오스티움에
Maybe mainly, intima hyperplasia.
lumen,
Would be the
스텐 lumen 좀.
main mechanism for these particular cases. And we are planned to fix up the circumflex ostium, so inevitably we have to touch the LAD. And actually we don't, need too much. It's really ischemic or not ischemic, the LAD part. And so this is, okay.
Actually, the FFR measurement is very important, but I think in this case, we have to touch the both sides. We cannot treat only the circumflex ostium. There is some stenosis. So if I want to treat the circumflex ostium, I have to touch the left main to the LAD simultaneously. So FFR is important, but in this case, FFR is not, I think it's not inevitable. So ostium of circumflex, this is ostium of circumflex.
No, I think it's more proximal than that, isn't it? That's too big an area.
More proximal. Yeah, measure the stent area. So here is a very austere portion of circumflex. Okay, roughly around the 5. Our previous criteria is around the 5. Recently, we show that the 5.7 is a criteria, very borderline, the circumflex austere area. But I like to show you that the previous OCT finding, at the initial, the PCI. No, I was finding. Yeah. 네. 띄워주세요. 팩스 영상으로 해주십시오. 네, run please. This is the final IVUS. Just 조금 더 뒤로 가서. 네, run please. This is the final IVUS at the first stenting. Here is the circumflex pullback.
Previous.
Stop. Okay, here is a very ostium. But I think the mechanism would be the neo-intima hyperplasia plus, look at compared with today's IVUS imaging, the 1 year ago circumflex ostium looks bigger stent. So neo-intima plus suspicious some stent shrinkage. is another
Kind of a contraction, constriction.
yeah, a little bit constriction.
Was it treated with crush or tap at first
Crush.
procedure?
Crush technique.
Anyway, when I published IVUS data from the two-stent technique about 10 years ago, we found that both the stent under expansion and the tissue proliferation both are the cause of the instant restenosis in the patient with treated with the two-stent technique. Actually, we don't understand why the tissue proliferation is higher in the circumflex ostium. Is definitely we have a lot of tissue, and the two-stent technique treated the left main. So it's a very typical case of ISL in two-stent technique.
Great.
So could you show us on the OCT? We also pull back the OCT from the circumflex to the left main. Actually, because of a tight stenosis, the OCT pullback is not easy. But anyway, we successfully get a good imaging. Could you show us?
OCT?
OCT로 좀 바꿔주세요. 네. Run, please. Here is a very ostium of circumflex.
Mainly
Stop.
intima.
Here is the main. Yeah. So there are lots of neo-intima. So mainly neo-intima hyperplasia plus a little bit stent shrinkage. Constriction would be the main mechanism of this patient instant restenosis, I think.
Anyway, if you look at the angiographic findings, there are lots of fluoroscopic calciums. These are part of main and proximal, even though the circumflex ostium. The reason why immediate after the large lumen, it's a little bit larger effective stent area. However, 1 year later, the constriction, contraction of a stented area may be related with a chronic, adaptation with the calcified, lesion itself. And so we don't know exactly is not related with the natural, progress of atherosclerosis or not. And so, however, all right. So, what is next?
Yeah, my plan is the one panel just suggested that he makes every effort to avoid the two-stent for the left main ISR. I fully agree with his opinion. So my plan is after very aggressive high pressure volume dilatation, and then finally, if the stent result is good, and I'd like to apply the coated balloon. So,
Did you do IVUS from LAD to the main door?
Yes. Could you show us the IVUS from LAD to left main? This is LAD to left main. LAD stent is very fully expanded. Vessel size is more than 4. Stent size is 4.5, around 4.
Big one.
Yeah.
Closer. So the proximal.
Yeah, here is a very proximal circumflex coming from the 5 o'clock. Here, this is the left main. Here is shaft toward left main.
Relatively good expansion, right?
Yeah,
Good
right.
Effective stent area is maintained.
Yeah, right.
And so
Yeah,
it's a little bit different with the angiographic findings.
yeah. We measured the minimal lumen area at the ostium of LAD, so 5.5 inside the lumen. Stent size is bigger than 6, I think 6, 7, and 8, something. So anyway, I like to apply the high pressure volume dilatation 3.25 according to the IVUS finding. IVUS finding show that the vessel size is almost 3.5 for circumflex.
Any opinion for non-compliant balloon for circumflex ostium or cutting balloon or any, can you tell us any difference over there?
Non-compliant to start with, but if it slips, definitely a cutting balloon can also help, get you to grip. So either.
So even though the stent is constricted a little bit, most of it is neointimal proliferation. And this origin of circumflex is such a culprit so many times in left main, right? For some reason, it almost makes you wonder if new technology needs to be developed to create stents with even more drug. Maybe there should be a super powerful drug-eluting stent to go with certain locations where we have a lot of trouble with
Circumflex.
neointimal
10.
proliferation. Just a thought.
Deflation.
Because when you get this open, regardless of how you do it, we will still have the question of this area is very vulnerable to neointimal proliferation. So drug-eluting balloon, okay, that might be enough. But you had the drug already the first time around, which didn't solve the problem. So we had a technology that I don't know if you have. I don't want to jump right now to radiation or something like that. But even when you open this stent a little more, we'll still be faced with this question of why such a powerful neointimal signal is going on in this area.
Deflation.
What size? 35?
3.25.
25?
Yes.
And up to what pressure?
18.
18.
Yeah.
It is a cutting balloon or?
No, high pressure balloon.
No, it's a non-compliant balloon. Yeah.
This is
3.25.
non-compliant balloon. 3 to 5 non-compliant balloon.
You apply the 18 atmosphere, right?
Yes.
What is the high
18.
pressure?
At least 18. Personally, I think the more than 20 is high pressure. But look at there is no indentation in the balloon, so well expanded. So 20.
20. 3.25. Finally, what is the balloon
What is the
diameter?
final balloon size? 3.35.
3.35.
Yeah. LAD.
Great.
20.
LAD. Only sequence of high
20.
pressures. What size?
4O high pressure balloon.
4O. Still
20.
uninflated areas, proximal area.
24.
24.
Not fully expanded.
Yeah. This is due to the extra stent calcification, deflation.
Maybe effective stent area is quite good enough.
Yeah.
However, outside of calcium,
20 complex.
So this looks like you may need the OPN balloon in the LAD.
But unfortunately, OPM balloon is not available in Korea. So the lithotripsy is not available. I think for this patient, the lithotripsy is a good indication for further expansion, good expansion for LAD stent. 10.
10.
Yeah.
All right. Finally, kissing balloon inflation.
1, 2, 3. ten 한번 더 하자. 하자. 10. Deflation. Some slippage.
Slipping down.
Yeah. 다시
More
10.
proximal.
Okay, good.
Perfect.
1, 2, 3.
The ostium of LAD is still underexpanded. Yes, the balloon is not fully expanded there.
Yeah, right. I fully agree with your opinion. So angiographically, the underexpanded, but inside the lumen perspective, lumen is, I think, quite enough. So yes, we can use the further balloon dilatation, but sometimes it makes the vessel rupture or something. So after angiogram, I will decide the further high pressure or not.
What do you think the mechanism is of that restriction in the ostium of the LAD? Is it external calcification that we can't quite see fluoroscopically?
Just a moment.
Why,
Test. Test.
yeah.
Ready?
Perfect. I think it's almost perfect one, right? Full expansion of a circumflex. Would you show us a spider view again?
Yeah.
Right now?
Ready?
Perfect.
I think I love it. I like it. So circumflex ostium is fully expanded, and LAD ostium compared with the left main, because left main is huge. So the looks a little bit small, but based on the IVUS minimal lumen is 5.5. I applied the high pressure, so the lumen is quite enough.
Okay, so what is next?
So I'd like
IVUS?
to apply the DCB both
Drug-eluting
sides.
balloon
Yes.
in the
Three.
circumflex and LAD though? LAD?
Yeah. Both.
Okay, good.
Yeah. 3.020. LAD 3.55.
So the original drug delivered was sirolimus or something like sirolimus, right? The stent was, I've forgotten what kind of stent it was.
Giants. Everolimus.
Giant stent, so it was, and now we're going to change to paclitaxel, right? Is that the-
Yeah, right.
Yeah.
Good
So-
point.
So, do we have any evidence that responsive proliferation might be different with the different drugs?
In Korea, only the public.
Anyway, a little bit difference. Even in the drug-eluting balloon, currently they made a, seed-olimus eluting, drug-eluting balloon. However, we don't know if the basic mechanism of a paclitaxel is a little bit more, advantage for just the drug
complex,
release, more lipophilic. So we can use high concentrations and on the balloon, something like that. And so. We don't know, so we need more data. But
And just, from my perspective, if one drug didn't work, you might try the other one.
Absolutely.
10, 12.
is this DB?
Yes, TV.
What size?
Circumflex 3.020. LAD is 3.5 20.
20.
Yeah.
How long duration would you
At
inflate?
least 30 seconds, 30 minutes. 30 seconds. Sorry.
Looks
30
nice.
seconds. 3035.
I
even though-
expected the DB one by one, not the kissing DB.
Take the one,
Yeah.
and so how long? The longer duration, the better?
I mean, the DB one by one, LAD or
right,
circumflex. The DB kissing is very not frequently seen.
So we is this a little bit smaller? We choose the smaller DB, the regulating balloon, and we don't want to make any disruption in terms of anatomic disruption, coronary shift or something like that, and so depending on. I think
this-
nothing too.
Is this 7
So-
French guide for?
Yeah, 7 French guide. So the look at the some left main patient the short duration of balloon dilatation changed his blood pressure or the symptom cause symptom, but this patient even the final kissing balloon long duration deflation.
minute?
So yes, So don't
Even
don't
in the
change
left
the
main intervention, David, it's not surprising. It's a 1 minute inflation. It's a totally occluded left main. It's
But if
would it be okay for?
ischemic
We didn't
precondition.
realize that one, right? Okay, and
final
picture.
angio, and I like to finish my procedure. So during the procedure, patient is just so stable, no chest pain, no complaint. Ready?
Oh, lovely. I think it's perfect, right?
It's very nice.
And another view, audio.
Ready? Okay.
Perfect. Widening of the circumflex stem with just only non-compliant balloon, high pressure more than 20 atmosphere, etc. And so, Dr. An, would you do the imaging for that?
Oh,
Obvious OCT.
okay, just a moment. I
All right.
already removed the wire.
Don't finish. And so we will be back and
Yeah.
after your pictures and so.
Okay.
Dr. Bak, Dr. Bak, can you hear me?
Okay, can you
Great.
can you hear us?
Good morning. Right. Of
Okay,
course.
good
And so-
morning. Good morning. Thank you for joining third day, and this is a third day morning live case demonstration. Before starting, I'm gonna introduce our team. I'm D.W. Park from Asan Medical Center, and the first assistant is Seok in the professor in Gyeongsang University. She is our alumni, and Jin-Ho Park in the is our senior fellow, and our technician is the standby. Also, Jin-Ho, can you briefly introduce the patient background?
Thanks for introducing me. I'm Jin-Ho Lee from Asan Medical Center. I'm presenting today's case. A 76-year-old male patient was admitted for stable angina. Coronary angiogram showed a severe diffuse stenosis at proximal to mid LCA and significant stenosis at left main proximal LAD. PCI at the proximal mid LCA was performed 3 weeks ago, and now revascularization of LCA was planned. He had past medical history, had no past medical history about coronary artery disease, and he had intestinal lung disease on stable status, and lung function is not bad. Next. In demographic characteristics, he has no risk factor, including diabetes, hypertension, and no hyperlipidemia. The clinical presentation is stable angina. Next. Electrocardiogram show basically normal sinus rhythm and no specific ST change here. Next. In chest radiograph, there's no pulmonary edema and cardiomegaly. Next. And we checked the echocardiography, and they show a normal LV systolic function without regional wall motion abnormality. And now we see the coronary angiogram. Next. In the RCA coronary angiogram show very diffuse and mild stenosis. And so 3 weeks ago, we put the stent with the 2 long stent. Next. The left side view is a caudal view. You can see the mild stenosis at the circumflex artery and also left main to proximal LAD or severe stenosis. In the cranial view, you can see the mid portion of LAD have some intermediate stenosis. Next. You can see the LAO cranial view. Disease extend to the main ostium, and you can see also spider view, and you can see some definitely the main disease.
Titus
So
stenosis.
Okay, so and today we already checked the IVUS. Could you show the angiography? Could you show angio? So, and the first, let me summarize this patient, the 76 and elderly male presented with unstable angina, and the right coronary already picks up, put the 2 long giant stent. And the initial impression is left main disease. It's not severe much. Dr. Jung-Min case, our Asan Medical Center philosophy, complex case assigned the junior, less complex case assigned the senior. This is our philosophy. So, and however, don't underestimate this case. There are many things we discuss, and looking at this is area coral view, by definition, left main seems like visual estimation 50 or 60%, and the Seok ostium looks okay. And next one. So this is a epicranial view. You can see that there was some intermediate left main lesion by definition, and geographically also approximate LAD. There seems to be some tight region. Okay, next. So, and this is a spiral view. You can see the Seok ostium was well open. Seok is just intermediate disease, left main. By definition, absolutely intermediate disease visual estimation 50 or 60%, and the mid-LAD part some narrowed portion. So at this moment, we think about how do we treat such ambiguous and intermediate left main lesion. For instance, Excel trial, looking at the inclusion criteria, in Excel trial, visual estimation more than 70%, they do randomization, PCI versus bypass surgery. Visual estimation, diameter stenosis, 50 to 70%, they do something. First, IVUS evaluation, lumen area less than 6.0, they do randomization. They regarded significant left main disease, or FFR, less than 0.8, they regarded significant left main disease and randomization. So by looks and geographical, we don't know. This is the real left main case, is how much significant by visual estimation. We already checked IVUS in both branch. We already checked FFR whole branch. We know answer. At this moment, I would like opinion panel and moderator. How do you think about this? Some looks like intermediate left main disease.
Good. So, any opinions?
I don't think it's intermediate. I think it's tubular and heavily diseased throughout. I mean, if you look at the circumflex is nearly 4, the LAD is nearly 4, so that's 8, so 2/3 of 8 is 6. So the left main should be 6 in diameter, and here we've got about 3 along the whole length. And actually, if you look at the very ostium of the left main, you can see it's substantially larger. So I think it's diffuse, heavy disease along the entire length of the left main.
David, you think about 60%
you did IVUS and you've done FFR. And my question is, what if they're discordant?
Yeah, that is the most important question. If FFR more than 0.8, something like 8.3, 8.4, do you leave it alone, or what is the next step? Do you do IVUS, or do you do something?
I think.
Actually, we don't, patient 76, stable angina, and we took a picture like this, and so we don't need a FFR for that. IVUS utilization support is mainly used, how much good, result to obtain.
But in this case, he did both, I think.
Yeah.
We're in a conundrum.
If the reason very confined to the main itself, FFR still work, right? However, there are lots of downstream diseases that are mixed pattern. It's just we, got the FFR numbers. However, the significance of the main disease, I think, is quite enough. So,
I think we need to consider the age of this patient, 76 years old. And I'm not sure the functional capacity of this patient is very active or very passive. But I think best test to test the significance of this lesion is a treadmill test, actually. The patient is not active. You don't need the patient don't have ischemia in the daily activity.
You mean medical treatment?
I mean, test the patient with the exercise test, not the FFL, not the IVUS. Do you think FFL, IVUS, same criteria for all the patient, young or the old?
If the main disease is significant, lots of ischemia, still you want to do the medical treatment for that?
I prefer, if you insist that the IVUS or FFL, I insist that the FFL actually.
All right. So
the IVUS criteria is quite influenced by the size, body weight.
Actually.
I don't agree medical treatment for this way. 76
I
is still,
I don't insist on medical treatment.
76
You don't
is still
test
young.
with a more
so,
appropriate manner.
all right, David,
Actually,
Taggart.
So from my perspective, this is very different from the first case. This is a 76-year-old patient, so it changes your philosophy of management. When I look at this angiogram, I find it very difficult to know how severe this stenosis is angiographically. And we know from FAME that unless you have a lesion above 90%, the eye is not good at assessing how severe a stenosis is. So I think the fact you've done some further assessment of this is extremely important in a 76-year-old. And I think here I would be very, very much more and very pro if the patient needs intervention is to take a PCI approach. The other thing that is, I think, important here is there is not additional significant other proximal coronary artery disease. So I think if I had been asked to see this patient, I think if you confirm that this is functionally important, then I think a PCI approach would be my number one option.
For the Dr. Bach,
Yes.
so we have enough time.
Yes,
So
we have enough time.
Before the imaging
PCI
study,
take 5 minutes.
enough time. Before the imaging study, why don't you do the FFR for that?
Yes, so, and we already checked the FFR.
All right,
so,
great.
the Excel trial looking at the QCA data, half of patient, QCA definition more than 70%, half of patient between 50 to 70%. That means, less severe left main is half of patient. We checked the FFR. Could you show us
Could you show
epicranial
us?
view? Yes. So, and the FFR, can you see
Digital
FFR?
LED?
Okay, so,
Oh.
and we measure the FFR from
Quite severe, right?
just the distal, the prox LAD region. That is 0.61, just the distal prox LAD region.
Actually,
and
this
here,
FFR value is a summation of main disease and
Absolutely,
prox LAD
absolutely.
disease,
Yeah,
whole
yeah.
summation of
Absolutely.
ischemic size-wise, and so. Okay, Dr. Gwon.
Okay, and
Still,
here,
you want to
we
do medical
slightly-
treatment for this patient?
How much was the step up in the left main?
Okay, we also showing step up, and we pull back past the prox LAD region. So, and the LAD ostium was 0.71.
0.71.
Yeah, and how do you decide? Is
So
ischemia,
one more
ischemia
thing
trend?
I'd like to mention about FFR is that FFR less than 0.88 is not necessarily ischemic. The only one thing for sure is that over 0.8, you can safely defer the patient. Lower than 0.8, actually we don't know. There's possibly ischemic. But we need to consider the functional capacity of the
More than
patient.
0.88 means simply no ischemia at all, right?
Right,
We don't need to treat them, right? So before FFRs, we know that patient had a stable angina symptoms and chronic angiogram, spider view data is more than 50, extended disease, prox LAD, and so we decide, this is a significant disease, and so you're going to do the PCI, right? So the meaning is you just mentioned about the medical
I agree with more than 0.8 or less than 0.8. It doesn't meet ischemia always. And then
Yes,
you need
and
to consider the
yeah,
age.
my
and the
question is,
functional
Professor Gwon,
capacity.
at this case, you usually do FFR widely, and or
So,
just
would you show us the
imaging value?
IBUS?
Okay, so and the FFR absolutely, definitely, less than 0.8, and the distal LAD, the mid LAD 0.61, and the LAD ostium 0.71. We checked the IBUS. Okay, could you show IBUS the LAD? Okay. So, and here is the distal LAD part. Yes, and there is some coming, the diagonal branch and septal branch. Lumen is quite small. Vessel size is 3.2. Here is the narrowest part, and the lumen area just less than 2.5, and the huge plaque. And here is the vessel size 3.5 also, and we're gonna do pullback. Okay, here is big diagonal branch.
Still LAD?
Yeah, still LAD. The spider view 바꾸고 이거. Okay, here is still LAD. So, and this is the prox LAD part. And here is the LAD ostium, and is the Lamus branch first coming here. And then Seok branch coming the 1 o'clock. And here is the distal left main. Yeah, is beyond your initial impression in the by visual estimation. Yeah, absolutely huge plaque, and the most narrowest part is plaque was extended to the left main. Is the most narrowest part the left main is a 3 point. Could you show us? 3.998. Yes, is that is absolutely.
Would you show us big screen those?
Yes.
All right, great.
Okay, here. This is the distal main, 3.98.
All right.
That is meet the IBUS inclusion criteria, XL 6.0. In our Asan Medical Center data, the matched value, Spencer King is pointed out there is some mismatch FFR value and the imaging value in our case series of the left main, and the lumen area 4.6 is matched the FFR 0.8. There is some difference, and Hamilos data is 15 years ago 6.0 is regarded as a criteria. In our Asan medical data included 300 cases. 4.6 is matched the 0.8. Yes,
great.
This patient is 3.98.
So, Dr. Spencer, you suggest, before the procedures, IVUS and FFR, match, mismatch concerns. So we have some data. If there are no disease at all, epicardial arteries, if the disease confined to the left main, the cutoff value of a minimal area is 4.5 millimeter square. Less than that, almost more than 80% is positive FFR, main disease, right? And another justice data have a little bit bigger cutoff value, 6 millimeter square something. If there was a downstream disease, just like this, this case is, the main area is around 5.5, 6 millimeter square. Still, the patient had a positive FFR. The reason why there are some downstream disease. And so, particularly these cases, we didn't do the FFR, so we are clinically all right. This patient has a ischemia, and so we want to treat them and obvious, just to save the money though. Lumen area just 3.9 millimeter square, absolutely positive FFR, right? So
let me raise one other technology that's present here. It's out of date, but there's an angiogram here.
Great.
And you see that the size, what size guide catheter is that?
Catheter? What size?
7 French? 7 French. It's 7 French guide catheter.
7 French. So what's the diameter of a 7 French guide catheter?
2.7 something?
So the left main is smaller than that, and the left main looks very much like the IVUS in terms of this angiogram. So we always say the angiogram is no good, but actually here, I think the angiogram shows you precisely the tubular left main you mentioned, yeah.
Great. So what do you do there?
Okay, so and could you show Seok ostium? And the Seok ostium, we also checked here the Seok ostium is lumen is okay. There is some plaque, but however, and the Seok ostium looks okay. So I think in this moment everybody agreed that simply is better. Stand crossover is good option. The Seok ostium was
this is circumflex, right?
Yeah, this is Seok ostium. It's good.
Ostial part.
Yeah, slightly some disease, but however, Seok ostium is good. So, we have a lot of discussion, but procedure is very simple. It's based on IBUS criteria. Most cases, 100 cases, we do IBUS evaluation for the complex PCI, and the recent study performed in Samsung and the Renovate complex PCI, imaging guided is better than angiographic guided PCI, and this case shows how much imaging was important. Also, physiologic guided PCI is also important in contemporary, the PCI practice. And this is 3.25 on the basis of the IBUS. The 38, just one stent. Okay, test.
You want to do one stent crossover, right?
Yes, sir.
Don't touch.
Okay, test. 저 위로 가야지. Okay, test.
A little bit short.
Okay.
We need a little bit longer stent right there.
Okay.
Cover the
Test.
proximality.
여기다 그지? Okay, we check it up the several view. Okay, test. 짧은데.
Ostium
Is
oblongate.
it long enough to catch that distal part?
Okay, test.
What length?
It's a bit too
Looks
short.
like it's ending.
October,
right
what length of
This is a 38 by IBIS. We changed the first. We require 2 stand. 자, 잘라서 한번 줘보시.
So
Okay.
48 millimeter is quite enough, right?
48도 있어. 줘보시. 48. 3.25.
So you're going to do full lesion coverage
Yeah,
from the
absolutely.
proximal to the majors, right?
괜찮아?
And circumflex ostial part is not, too much disease, and so we're
Absolutely.
going to just do stent crossover, right?
This is 48. The Giants. Sky Point.
I think this is a great case showing the importance of using both functional assessment as well as
Absolutely,
intravascular
absolutely.
imaging in intermediate left main coronary artery lesion. I'm just wondering whether in Asan you also use IFR, because we also know that IFR has the use of IFR has also been validated in intermediate left main coronary artery lesion, and with IFR, especially if we have facility for co-registration, then we can better identify which lesion should be treated first, which lesion has the biggest delta.
Okay, test.
And then proximal optimization.
Slightly. Okay, test. Yes. Slightly push it up. Okay, test. Okay, I think here is good. The pressure is okay. Okay, test. Okay, go.
Perfect.
6, 4, 5, 6, 7, 8.
What's size? 35?
This is 3.5.
All right.
Okay, deep
48.
And then we're gonna do sequential high pressure balloon using different size.
Actually, what stent do you use?
This is a giant stent.
All right. Johnson.
Yes, the light side we put the giant sky point. This is also put the giant sky point. And then we do the step-by-step high pressure balloon, and this is 3.5.
This is a little bit commercial question. Taggart, do you have
Yes.
any preference of a different type of drug stent?
So I'm a fair person. I'm selected equally. I think we are published the data about among the several different type of second generation contemporary drug stent, and we didn't find any difference at all in terms of DSMI stroke, DSMI TRR that was published a couple of years ago in JACC.
Any difference of any different drug-eluting stent? Do you believe?
Yes, yeah, we,
Right, I know.
yeah.
I mean, in the States, we have the 48 only is the Boston Scientific stent that we have. But for osteo lesions, my preference is Zions because of the space from the dot where the stent finishes, the radio opaque top.
4, 5, 6.
So it's for landing is a little bit more accurate.
Actually, we tested that hypothesis, difference of second generation DS in the bifurcation lesion in the COPISTA 3 registry. And the hypothesis is that the science is better than others in terms of 3-point connections between the crowns, more stable structure after the sideways ballooning. But we couldn't find that. There is no difference at all between the DSs.
Right. So anyway, current, you know,
4.0.
Dregel-Tungsten is almost same. So we don't
Even in the
make any
bifurcation.
difference at all.
Even in the bifurcation.
So I would like to question to the panel and the moderator, how do you think about the FFR guided left main PCI? You know, FFR was evaluated various disease, intermediate disease and multivessel disease, and the FAME study 1 to 3 shows the FFR guided PCI would be okay. So, but in the left main disease, FFR is not yet fully evaluated. How do you think about that concept? Okay.
High pressure? High pressure?
Yes, 4.0 and NC balloon. Here is go. 12, 14, 16, 18.
18.
Okay.
18. 4.0,
Yes, 4.0.
18 atmosphere.
Absolutely. Okay, 20.
20.
16, 18, 20.
Yes.
What size?
Okay.
Finally,
This is, yes, 4.0, 20. What size? 4.25. Okay,
4.5?
here, 4.25.
all right.
Okay, the
Big enough.
nitro, and then we will check it up angio and IBUS.
Okay, we're gonna see is what's happened circumflex ostium.
Yes, yes.
I have a question. Would you recross to Circ?
No. Not,
No,
not
usually, okay, nitro 줬어?
Not in this
한번
setting. I mean,
angio
he's
찍어보자.
a slightly older man. There's no disease in the circ. You win some and you lose some, don't you? If you do recross and do
Okay.
kissing inflation, you
Second
disturb
찍어야 돼.
the architecture of your stent.
자,
So it's not really necessary here.
Perfect, perfect. So no
circ-
significant compromise of the circumflex ostium too.
so, and some data in the Korean data in the angiographically over here, angio.
Okay, we expect that one.
Good.
Perfect, right?
Absolutely, you know, Seok ostium looks like some angiographically significant, and some the study shows the FFR full evaluation. Seok ostium FFR more than 0.8, they do just leave it alone. Less than 0.8, they do kissing balloon dilation. Even leave it alone, the long-term follow-up data is okay. So, and that means FFR work for, you know, Seok region for like some left main crossover case. So I'm gonna check the IBUS. So, and the, you know, spiral view and the Lamus branch is okay. The Seok ostium is okay. So we will check the, we have a lot of,
I would follow my leader's advice here. Don't touch the circumflex.
Even in the normal-looking circumflex, always like this. Even, you know, after the main stent crossover, you know, 70, 80% of a compromise, discrete narrowing, functionally, you know, more than 93%, 90% is negative FFR. And so we really believe in the normal-looking circumflex, just the stent crossover is clear enough. Right?
distal edge, there is no dissection, it's a fully expanded. 30-minute discussion, 5-minute PCI.
Great. Stent diameter is more than 3, right?
Yeah, absolutely. And we put the 3.25 48. We are sequentially dilated distal part using 3.5 high pressure balloon. Left main part, we use a 4.0 high pressure balloon inflated up to 20 ATM. Here is the proxenetity part. So we performed the high pressure balloon.
Circumflex?
Not yet. This is a big diagonal branch. Yeah. So
Okay.
yeah, proxenetity.
Is it this part is the main? Yeah.
No, not yet. This is proxenetity, and we put the 48. So and the proxenetity we inflated the 20 ATM using 3.5 balloon.
Almost
So
5.
yeah, it's coming from the, and this is the added ostium Lamus branch first coming, and then the Seok branch is coming.
Stent diameter is almost 4.
Yeah, yeah, absolutely. And we performed the 4.0 20 ATM. Good. It's fully expanded.
Great.
So exact positioning
Perfect.
is the left main. Absolutely, ostium was fully covered and 1 or
Very
2
much
millimeter.
precise placement of the stent.
Absolutely.
Ostium, remain.
Yes. I'm remove the and check it up the final shot. Okay, Angel.
So you don't need a measure the stent area.
Yes.
yeah.
Could you measure? Okay.
Would you show us then?
Angel, ready?
You're gonna have more confidence, right? Minimal lumen area,
So ostium is okay.
LAD and remain.
Here. 여기서 한번 재보자. Good. Here.
Perfect, almost perfect.
Yes, and the
I
cranial.
like that.
Good.
Perfect.
Yes. So, and the distal edge, there is no dissection. You know, it's a fully expanded, and the stent optimization was
Would you show us
excellent.
IBS imaging in the big
Yes.
screen?
Could you show us IBUS imaging big
IBS imaging in
screen?
the big. All right, great.
Okay.
This is LAD.
Okay. This is LAD. Yeah, LAD was expanded at least 8.0. This is prox LAD part. Could you show LAD ostium? LAD ostium.
High enough, big enough.
Yes. Here is the LAD ostium. Yes, it's more than 10 at least. And could you measure area?
LAD ostium,
Yes.
maybe 11
11.
to 12
yes,
millimeter
12.
scale.
Yes. Okay,
Or
13.
more than
and
that,
the, and the distal main.
Prox
Okay.
LAD is more than
Yeah,
13. And the main,
Yeah, this is the main. It's more than 14. Could you show us the spider?
more than that.
Yes, more than
11.
12. So I think this case relatively
All right.
looks simple. We have a lot of, discussing point. It's like some relatively less severe, ambiguous intervened left main lesion. How can you do decision making in such case? You just believe your visual estimation. You just believe FFR. You just believe imaging. I think this case is a very representative case. Imaging and physiology assisted contemporary state-of-art PCI. And there are lots of, supporting adjunctive tool to help our PCI practice. And last year, we performed FFR more than 3,500 cases. Almost all PCI cases, we used intravascular ultrasound. You want to do that? Absolutely, you can 100% optimization your procedure, especially for complex PCI.
Great. I think he's a really good candidate for stent procedure. So if you look
I
at
believe
the...
even Dr. Taggart agrees with us there.
I completely agree. I think this is, in contrast to the first case, I completely support this approach. I think it's excellent.
Yes, and so if you look at the effective stent area is more than 8 millimeter, 10, 12 millimeter scale. We got some data, 5 years, TLR rate is less than 2%, almost perfect. And Dr. Gwon suggests is whatever you use the two-stent technique, our data only predictor for long-term is effective stent area, how much big it is, right? So we have a very, right? Anyways, bigger than that, 5, 6, 7, 8 millimeter scale is quite enough to maintain the good clinical outcome. All right, Dr. Bach is perfect case. It's really, like David Taggart agree with your,
Thank you, David.
all the procedures. All right, good. Thank you for
Very
your
nice.
cases.
Thank you. 잘했어요.
Okay, move on to the Dr. An. All right. Oh,
Yeah.
why you alone?
Because I already finished the patient transfer for the CCU. Anyway, could you show us the angio first? This is the final angiogram. Angiogram looks fine. No stenosis, very widely expanded, no indentation. So can you show the IVUS imaging from LAD pullback? Run, please. This is proximal LAD. Stent is very big. I applied the 4O high pressure balloon. There is some neo-intima dissection, but the lumen is quite good. Circumference is coming from the 4 o'clock. Opening looks very fine, but we have to know that the LAD pullback overestimated the circumflex ostium. So we have to see the direct circumflex pullback imaging. So we also evaluated the IVUS pullback from the circumflex to the LAD, left main. Could you show us that? So I applied the 3.25 high pressure balloon and finally the coated balloon side. Yeah, right.
Good.
Stop.
Ostium here?
Yeah.
Oh.
Yeah. Very
Getting better,
ostium
right?
is
Getting
yeah,
bigger.
getting bigger. Could you measure the lumen?
Lumen area?
Yeah.
Circumflex ostium? Maybe 5 enough. All
Yeah.
right, 6 is good.
Yeah.
The bigger the better.
So run, please. So here is the circumflex ostium getting bigger than before. So here is just a left main. So I was finding show the very acceptable. So based on this is a second procedure, but considering the second procedure, even though the final IVUS and angio finding is very nice. So can I ask you, Taggart, how about this procedure?
You didn't do OCT though.
Actually, OCT, we didn't do OCT. Yeah.
All right.
Yeah.
Okay, I think it's also good, right? Result.
It's a good result. The neoenema is now displaced through the stent into the wall of the artery, and we're depending on the drug-eluting balloon to solve that problem. My question is, how often does it solve it in this setting? What is the experience in terms of whether a year from now we're back at the same place? I don't know the answer. I'm asking, what is your local experience regarding in-stent restenosis of this sort and solving it with the drug-eluting balloon, which we don't have yet, and I'm very interested in knowing what you think.
Some small, microscopic concern, still some tissue protrudings, remaining tissue over there. So actually, this is very old data. We compare with the cutting balloon and non-compliant high pressure balloon. Actually, we didn't find any difference between the two. And so nowadays, we do just, non-compliant balloon though. Dr. Han, it's really good cases.
I have one question.
All right. So thank you for explanation.
I have one question to the panel.
Okay.
One question.
Ask to the Dr. Han too.
That is in case of the second case, that is left main stenting, whether any role of opening of LCX start have any role on the outcome of opening of LCX start?
Can you?
This patient?
I missed that.
So I think it was the question about opening the stent struts into the circumflex, which we discussed, which in this kind of setting, without disease in the circumflex and without downstream disease or proximal disease in the circumflex or elsewhere, and in a more elderly patient, probably no advantage to disrupting your stent by doing a kissing inflation.
Actually, we have a data.
Sorry for that. Okay, we're gonna move. Dr. Park.
Actually, we have a data from the experimental study. If we have actually regular alignment of the stent stud, no limitation on the flow. The flow is okay. And the second, we checked around the 150 cases specimen, just a single stenting, no touch of circumflex ostium, and the long-term result is quite okay. Only just 2% restenosis because just like Karina shift, something like this. Usually perfectly okay.
So same data from Okutsu 3 out of 2,000 patients, but currently the randomized trial is going on about strut opening versus leave it alone. But I'm not sure it is really necessary. Just crossover is very safe according to the clinical outcome in many registries.
And sometimes the do something may increase the event rate for the main branch. I think for the bifurcation, main branch is far important than the side branches. So to do something to the side branch, unexpectedly hazard to the main branch, so higher maybe sometimes the leading to the high rate of event in the main branch. So the circumflex flow is very nice, and so there is no dissection, no symptoms. Then I recommend you to not to touch the circumflex and side branch. And one more comment is that recently we evaluated the impact of left main TLR on patient long-term mortality. We gathered 130 patients who experienced the left main TLR. But fortunately, the left main TLR is not associated with the patient's long-term mortality. So, yeah, the TLR, we thought that TLR is a benign process. So, but we thought that this is based on the non-left main restenosis. But for the left main restenosis, TLR is not that resulted in I think the benign, not a significant long-term event.
TLR is benign. Okay, any other issues and discussion point? All right, thank you, Taggart. It's really good, nice demonstration. And we're gonna move.
So we're slightly ahead of time, which is good, I think, if I'm correct on my watch. And we have the next talk is going to be regarding the current status of PCI and surgery for left main disease. We've heard a lot from David Taggart, who will give us a very unbiased view of this subject. Mr. Taggart.
Thank you very much, Mr. Chairman. Let me say good morning to everyone, and I would first like to start by thanking the organisers, especially Dr. S.J. Park and Dr. Duk-Woo Park, for the invitation to this superb scientific meeting. So I'm going to, in the next 10 minutes, talk about the current status of PCI versus CABG in left main disease. My conflicts of interest, as alluded to by Dr. King, is that I'm a cardiac surgeon, so I am going to give you my perspective from that point of view, but I will still try and present all the relevant information in a balanced way. My main conflicts of interest is that I was the chairman of the surgical committee of the EXCEL trial, but withdrew from the final publication in the New England Journal of Medicine. And I do have some commercial interests, but none of them relevant to this presentation. I'm going to start with a general and very important caution from a former editor of the New England Journal of Medicine, Dr. Marcia Angel. She wrote in 2009, "Conflicts of interest and biases exist in virtually every field of medicine, particularly those that rely heavily on drugs or devices. It is simply no longer possible to believe much of the clinical research that is published, or to rely on the judgment of trusted physicians or authoritative medical guidelines. I take no pleasure in this conclusion, which I reached slowly and reluctantly over my 2 decades as an editor of the New England Journal of Medicine." I will add 3 further cautions to that advice from Dr. Angel. Whenever we look at any evidence to do with PCI and CABG, there are always 3 rules we need to look at in terms of interpreting data. The first is, are the patients in trials typical of what we see in routine clinical practice in terms of severity of coronary artery disease and syntax scores? And the answer is usually no, because in most trials the patients are highly selected with less severe coronary artery disease. Nevertheless, the results of those trials are then extended to the whole population, as we've seen in the ischemia trial. Secondly, what is the duration of follow-up? I would argue it must be an absolute minimum of 5 years. Ideally, it should be 10 years, because with all of the studies we've seen, with increasing duration of follow-up, you see increasing survival benefits of bypass grafting. The third thing to ask yourself is, did the patients in the trials, the CABG patients, receive the same optimal medical therapy as the PCI patients? And the answer is usually no. And the importance of this is, if the CABG patients had received the same optimal medical therapy, then the benefits of CABG over PCI would have been further exaggerated. And the other point I would always make, whenever you look at a paper or a study, always look at the data before you read the text, because the text will often have a very pro-PCI bias. And I will show you that's what happened in the Excel trial. Now, back in 2008, this was the current state of the art of a review of all the evidence at that time comparing PCI and CABG. And at that time, we concluded CABG should be the preferred revascularization treatment candidates, or at least in good surgical candidates with unprotected left main stenosis. And this was based on two pathophysiological observations. The first is that up to 90% of patients with left main disease also have multivessel coronary artery disease, where there is already a survival benefit of CABG independent of the presence of left main. And the second point was that up to 90% of left mains have distal bifurcation lesions, which are known to be at high risk of restenosis. However, in the review of the literature, what we also observed were that there were excellent PCI outcomes for isolated ostial or mid-shaft lesions, and they were probably even better than what bypass grafting could offer. A few months after we published this, Dr. Park's group reported the main COMPARE registry. This was 2,248 patients, followed for 3 years, either receiving CABG or either bare metal or drug-eluting stents. Then the propensity matched PCI versus CABG patients, they reported that PCI with bare metal stents or drug-eluting stents led to non-significant increased hazard ratio for death or a composite endpoint of death, MI, or stroke, but did result in very much increased need for target vessel revascularization with a hazard ratio of 5. However, the importance of this observational study, which was the largest at the time reported for left main, was that this became the basis for the pre-combat trial of 600 patients of PCI versus CABG. However, in 2014, the subset of Syntax trial, 705 patients with left main, was reported. And this is some very important observational facts. The first is that if patients had a Syntax score of below 32, there was no difference between PCI and CABG in terms of clinical outcome. On the other hand, if the Syntax score was above 33, there was a very highly significant increase in MACE in patients with PCI compared to CABG. And there were 3 important implications of these findings. The first was that it showed the accelerating divergence of benefits in favor of CABG in Syntax scores above 32. And this was crucially important because this is what defined the Excel trial, in that patients, we decided when we constructed the Excel trial that we would exclude patients with Syntax scores above 32 from randomization to CABG or PCI because we felt that would be unethical for patients in that situation. And the third thing it raised was the implications of competitive flow. Why was there no difference in the results of CABG and PCI in patients with Syntax scores below 32? That's because it probably largely excluded those patients who had additional significant proximal coronary artery disease. So if we turn to the Excel trial, the 5-year results were published in the New England Journal in 2019. Now, what's important about Excel is it was the largest, most definitive trial of PCI versus CABG in left main disease. A caution is that the patients were relatively selected and that they had to have Syntax scores below 33. And that's very important because it contrasts our routine clinical practice where only 1/3 of patients have Syntax scores below 33. 1,905 patients were randomized out of an initial proposed sample of 2,600 patients, but randomization was stopped early, and it was never explained why randomization was stopped early. The mean age of these patients was 66, so that means they would have an anticipated life expectancy of 15 to 20 years if they receive the correct treatment. The primary outcome was a composite of death, MI, and stroke, but importantly, it did not include repeat revascularization. The other thing that was bizarre or peculiar about Excel was it used a new biochemical definition of myocardial infarction, but did not report the specified defined universal definition of MI. My centre in Oxford, between the cardiac surgeons and the cardiologists, were the second largest recruiters worldwide to the Excel trial. So we showed a very serious commitment to this trial in terms of what we thought was its clinical importance. There were 37 authors in the final paper, but I withdrew my name from the final publication. I think there were a number of concerns about the way the Excel trial, not the way it was conducted, but the way it was reported. The first was, if you look at death from any cause, you can see that at 5 years, there was an excess and accelerating mortality with PCI at 5 years. And this was disturbing because the mean age of these patients was 66 years, and they had low or intermediate severity coronary disease in terms of left main. At 5 years, in PCI, the risk of death was increased by almost 40%. There was a significant increase in non-procedural myocardial infarction, a significant increase in the need for repeat revascularization, but no difference in stroke. Now, the initial review of this paper by the editor of the New England Journal of Medicine stated, the finding of a higher mortality rate in one group than another in a clinical trial, unless the difference is clearly trivial, should receive central emphasis in the report of the results, and we would generally consider it important to include such information in the concluding statement in the final paragraph. And I agreed completely with this opinion. However, what actually happened? In the final paragraph when the paper was resubmitted, it said, in patients with left main coronary artery disease of lower or intermediate anatomical complexity, there was no significant difference between PCI and CABG with respect to the rates of the composite outcome of death, stroke, or myocardial infarction at 5 years. I disagreed with the fact that that's what the paper showed, so I withdrew from the manuscript. The other problem with the Excel trial was the reporting of myocardial infarction data, because this is what was used to define the primary outcome. Now, as I told you, the Excel trial used a new biochemical definition of MI that had not been used before, and if you see what happened 6 months later when the full myocardial infarction data was reported, you can see that the protocol definition of MI remained the same for PCI, with the third universal definition, so the standard way of reporting MI. But if you look at CABG patients, the risk of myocardial infarction decreased by 77% from 6.1 to 1.4%. So if the universal definition had been used in the initial primary outcome of this trial, it would have proven positive for bypass grafting. So what happened after the Excel? There was a ferocious attempt to dispel the results of the Excel trial. This was a paper published in the European Heart Journal a few months after the Excel trial, looking at 5 randomized trials, 4,600 patients, where it claimed there was no difference between mortality or any other significant outcome between PCI and CABG, except for the need for increased repeat revascularization in the PCI group. But this is what I would call meta-analysis magic. There were 14 authors of this paper, no surgeons. And what I think it did was it diluted the largest, most definitive trial of left main disease at Excel with 4 older, smaller, weaker studies until the mortality benefit of CABG disappeared. There was no indication that these were highly selected left main patients with relatively short-term follow-up. And the second part of the meta-analysis magic was the speed of the publication of this. This paper had 11 days from submission to review, to revision, to resubmission, and final acceptance. 11 days. So I would advise anyone in this audience who are thinking of submitting a paper, submit it to this journal. However, if you re-look at this data by Dr. James Brophy, a non-interventional cardiologist looking at the same data, he came to a different conclusion. He said Bayesian analysis assisted in randomized data interpretation and specifically suggested, whether based on Excel results alone or on the totality of available evidence, that PCI was associated with inferior long-term results for all events, including mortality, compared with CABG for patients with left main coronary artery disease. And then a further analysis of this data by Gaudino, Fremantle, and Farku, looking at the longest follow-up terms of all left main trials, they showed a very significant increase in survival benefit with CABG in patients with syntax scores, even in those below 33. So now let's look at the latest analysis, Sabatine and colleagues, published in the Lancet in 2021. This was an individual patient data meta-analysis, 4 randomized trials, syntax, pre-combat, Noble XL. Now note this, the median age of these patients was 66, so they should have an anticipated life expectancy of 15 to 20 years. The median syntax score was 25, so these were low to intermediate risk patients. 75% of them had syntax scores below 32, whereas in real-life clinical practice, 2/3 of patients have syntax scores above 32, and 25% had diabetes. Now, even in this relatively low intermediate population, the difference in mortality at 5 years was only 1%. But if you look at spontaneous MI and repeat revascularization, they were having a very rapid diverging increase at 5 years. And the stroke rates were not different. But as I said, remember, these are patients with an anticipated life expectancy of 15 to 20 years. And I would also point out the manuscript title gives no indication that these results apply to less than 1/3 of patients that we would see in routine clinical practice, except the trial implies that these results can be applied to all patients with left main disease. What else do we know? Well, Dr. Park's group, the pre-combat trial, 600 patients, relatively highly selected patients with low syntax scores, and they showed no survival difference at 10 years between PCI and CABG. However, if you look at the main compare registry, there's a very important message about the long-term follow-up of patients. Main compare showed no difference in mortality between PCI and CABG at 5 years. But when these patients were followed out to 10 years, we can then see that there is increased mortality in patients undergoing PCI in comparison to CABG. So this tells us how important long-term follow-up. The other thing Dr. Park's group showed was the importance of the location of that left main lesion. They compared in the main compare registry at 12 years the difference between ostial or shaft disease and patients with bifurcation disease. And they showed a very significant increase in the risk of mortality, MACE, and repeat revascularization beyond 5 years. So 2 things are important from Dr. Park's work: the duration of follow-up and where was the left main lesion. If you look in contemporary clinical practice for left main disease, 2/3 of patients have syntax scores above 33. And here there is a class 1A indication for CABG and class 3 for PCI, meaning these patients should not have PCI. And the same is true for 3-vessel disease, where 80% of patients have syntax scores above 22. But I would argue that the results of CABG would be even better if there was more use of arterial grafts and better use of medical therapy in CABG patients. So on that point, I think I've probably run a little bit over time, so I think I've made my message, and I will conclude at that point. I would again like to thank both Dr. Parks for the invitation to this superb scientific meeting, and you, the audience, for your attention. Thank you.
Great, great, thank you. All right, next to featured lectures, Dr. Spencer King give us many clinical trials failed to change practice, limb main and multivessel PCI. Spencer, everybody know that he is a father of our intervention cardiologist, and from the beginning of a balloon angioplasty, lots of young generation is get growing, and so I really he's a father of our intervention cardiology. So thank you for joining us these days, Spencer.
Well, S.J., thank you again. This is a fantastic meeting. It's brought so much in advancing of interventional cardiology. I'm reflecting on that, being at this meeting this time. because as I look at the technology, as I look at the trials, as I look at the publications coming out of this region in the last year, it's extremely clear to me that the whole era of trying to bring some knowledge to the Asian interventional cardiologist has become very fruitful, because now you are providing a massive amount of information that's going to help everybody in the world deal with these conditions that we deal with. I'm going to extend my comments a little bit beyond left main. We've heard so much about left main, but I'm reflecting on the whole concept of why we have all these trials, and what do we do with the results of them? Do we actually change our practice based on the trial results? I have nothing to disclose about this subject. Now, some trials do change practice. We've heard of things here at this meeting that have changed the way we do things. You've learned a lot that has influenced your outcome. We heard a lot about STEMI in this meeting, and clearly we're saving lives with STEMI, and the trials that initially showed that made STEMI intervention with PCI the standard of care. And so there are things that change our practice dramatically. TAVI, you might argue, has changed our practice. Some might argue that it's changed it more than it needs to at this point, but still it has made a major impact. But so there are trials that change what we do, and we'll continue to do that. But there are reasons that some trials do not change our practice, even though their results are positive. So here's some of the reasons. Studying questions when the answer is already known. And we do have trials that are put together that we pretty much know the answer, but for one reason or another, sometimes economic trials are done. We have trials that show negative or neutral results, and of course they frequently, as expected, don't change practice. We have superiority of unpopular therapies. The unpopular therapy wins, and we don't like that. We have failure of popular therapies to show benefit. We have something we really like, but it didn't show benefit, but we say, yeah, but maybe that's not my patient. We have statistically positive results. However, the clinical benefit is not impressive enough to convince the physician or the patient. And we have multiple trials of different therapies with no clear answer, going in sometimes different directions that confuses us. So I'll mention just some of these things. How about studying questions when the answer is already known? We got patients with severe obstructive coronary disease, with severe angina, clearly documented by the mechanism of decreased oxygen supply to the heart, and we design a trial to increase that oxygen supply versus not increase it. We can do that, but I mean, it's sort of, we know the answer and no point in doing it. We know that from clinical observations. There are clinical observations that we don't need to do trials to solve. There are trials with negative or neutral results. A great number of these, one stent versus another stent. These stents are almost identical, but we keep testing one versus the other, spending an enormous amount of money and energy trying to show not really superiority, but non-inferiority, and these are largely industry-driven trials, and they have to be done in order to get the labeling for the stent to be able to bring it to market. But do they really change practice? Well, they might change from one supplier to another based on cost or some other consideration, but the trial result is really not what's driving a change in practice. How about superiority of unpopular therapies? We've heard a lot about left main disease. What about the left main disease and decreased left ventricular function? We've got a lot of evidence about that we've heard about at this meeting.
And the trial results led to guideline recommendations, which you're all familiar with. The ACCHA SCI guidelines on revascularization say the following. In patients who require revascularization for significant left main coronary disease with high complexity, it is recommended to choose surgery over PCI to improve survival. And in patients who require revascularization for multivessel coronary disease with complex or diffuse disease, syntax above 33, as you've heard from David Taggart, it's reasonable to choose surgery over PCI. So this is what the American guidelines at least say about this subject. They also say things about diabetic patients and how this influences. These all come from trials. There's some evidence out there that suggests all these things. Question is, do those change our practice? Do we avoid doing PCI on those patients? You brought up the subject of patients above 33 syntax score and what's happening. What I'm finding in many places is that even though we know that data, even though we believe that data, we think that that may not apply to our patient. And what I'm seeing frequently is not that the heart team doesn't function, but the input of the heart team from the surgeons in the very high-risk patients, particularly with decreased left ventricular function, is, oh, this looks like a really tough case. Maybe you should try PCI. So we see surgeons sometimes dumping, I'll use that word, the patient on the interventional cardiologist. Although, if we go back to the data and the guidelines, we say, well, this one we think is better for a surgery. But the surgeon says, well, this is a very high risk. I don't want to take this on. So this does happen in some areas, and it remains a bit of a problem. How about statistically positive results but without clinical relevance? And we all know this. You can have things that we express relative reduction in events as 50% reduction of such things as that. But in fact, if the incidence of the outcome is low, that 50% reduction, if you got an incidence of 2%, is from the patient perspective, if you're doing informed consent with that patient, you say, we got a 50%, we can improve your chances by 50%, but what the patient wants to hear is, what are my chances of doing okay if I have it or I don't have it? You say, well, it's 99% if you have this, and if you don't have it, it's 98%. And the patient says, duh, what do I care? So we have to recognize that these are also things that sometimes we have statistical benefit, but the clinical benefit is not enough to impress the patient. Then there are trials that go in different directions. We've heard a lot at this meeting about antiplatelet therapy. Long DAP, shorter DAP, stop one drug, stop the other drug, et cetera, et cetera, et cetera. It is confusing to me. It's confusing in the guidelines. Here's the guideline chart for dual antiplatelet therapy, and it reflects all the trials that have occurred. But I look at my own institution, which involves about 7 or 8 hospitals, and one hospital goes this way, one likes longer DAP, one likes shorter DAP, and we have some consensus that acute syndrome patients need it longer and others don't. We have to take into consideration the bleeding risk of the patient. But does this really influence our practice? And then we've got failure of popular therapy to show benefit. And here's a trial of invasive versus conservative management of coronary disease named ischemia that you heard a great deal about here. This trial has now reported its 7-year results. And as you can see in the bell-shaped curve on the top, there is absolutely no difference in survival in the trial. The second one down shows, however, that for cardiac mortality, there's a benefit of revascularization. And then the third one down shows that for non-cardiac mortality, it goes in the absolute opposite direction, so there's no benefit. But pay attention to this bell-shaped curve, because I'll mention that again. These are the average outcomes of our patients, and what we as interventional cardiologists want to believe, this is a popular therapy. We think revascularization, the surgeons as well, I would say, want to believe in this therapy. The trial comes out that therapy doesn't do anything for survival. Does this change our practice? Where do we come down? When we see a patient with stable ischemic heart disease and a certain amount of ischemia and they've got coronary disease, do we say, did we quit doing angioplasty? Did we quit doing surgery because we tell the patient, we cannot really influence your survival? Or do we believe that's what the trial shows, but are you like that patient in the trial? Having said all these negative things, trials are necessary to dislodge our incorrect beliefs. We have to do trials. Trials are the gold standard. A current trial aimed at establishing that imaging should be part of PCI is the one from here, the Renovate Complex PCI trial, which you've also heard a lot about here. And as strong as this trial is in showing that intravascular imaging gives superior results compared with angiography alone, I suspect that practice will be changed by correcting 3 other things that have inhibited broad use of IVUS. Now, here, IVUS is used, as you see, very extensively. Around the world, in other places, it's not used so extensively. So what is inhibiting it? And I submit that it's lack of experience and training in IVUS. It's a prior history of poor reimbursement for IVUS. Don't get paid for it. It's a poor appreciation of the value of IVUS, and this kind of trial brings more evidence to that. So I think that the trial and the investigators concluded that this should be a requirement. This should be a quality measure. Do you do imaging in all your PCI procedures? But I suspect that this will change, but I think that it'll change because of increasing experience, hopefully increasing reimbursement, and appreciation of the value of IVUS. So trials do influence us, but they do not necessarily result in the change in practice, but the change in practice may come from many other things. And finally, is my patient like the trial patients? Remember the bell-shaped curve. Patients, the trial results are the average patient. For patients enrolled in trials, the average outcome is valid. However, trial populations are limited, and there's always a bell-shaped curve for benefit, and the trial patients are only a sample of the patients with the condition. The question is often, is my patient in the middle or at one or the other end of the curve, or even outside the study patients that were included?
Great.
Registries that contain all the patients of interest consistently show better outcomes with revascularization, but even with adjustment, confounders cannot be eliminated. However, registries, if you think about it, are closer to our personal clinical experience. If we look at all the patients, particularly a registry of your local institution, you know what's the outcome of your patients. You know the trial, that's an international study of everybody's patients, very selected. A registry can still be helpful understanding what your own local outcomes are and help to influence your opinions. Therefore, local experience often drives practice even more than clinical trials. So my conclusions are the results of clinical trials often point toward the need for change in practice. To achieve that, trials are often necessary, but they are seldom sufficient. Trialists should recognize this and plan to address unanswered questions with smarter trial design to target appropriate groups, identify clinically relevant endpoints, and I'll digress there for a moment and say that periprocedural MI should not be an endpoint. The patient doesn't know they have it. And importantly, for investigators to imagine whether the trial results will ultimately influence practice. Thank you very much.
Great insight for the lecture, from the lecture. All right, we are closed this session and move on. All right, you're gonna do next session. So all right, but
No science. No science.
This is a comment for David Taggart. Since you showed 3 papers with my name on it, so I feel compelled to answer. First of all, it was a very insightful presentation that you did. I'm not going to debate the Excel 5-year result. We've debated that to death, or the trial or the analysis that we did in JAC, where we showed the different outcomes and definitions of periprocedural MI. But I really like the fact that you called me a magician, because, and I take it as a compliment. And I want to thank you very much for it. The meta-analysis that we wrote for the European Heart Journal with my fellows from Colombia and other people from there, we did get a lot of criticism, but over a beer, we can discuss why I think this is not a bad analysis. But again, I take your characterization as Magic 1 and Magic 2 as a compliment. So thank you very much.
You're very welcome. And I just make one brief final comment with regards to what we see just now, and I've mentioned this. If you look at the ischemia study, which will be used very widely to change clinical practice, it's a very dangerous study. It enrolled highly selected patients, and its interpretation has been taken to look at all stable ischemic heart disease. So that means for patients with severe coronary artery disease, the average, so if the people writing the guidelines could not understand what ischemia showed, what hope does that give for the average doctor in practice? And the danger of ischemia is very widely quoted, is that it will be used to deprive patients with severe coronary artery disease from appropriate referral for revascularization, whether by PCI or CABG, but preferably for those patients with severe anatomical disease will no longer get referral for CABG. So it's a very dangerous study. And the point I was making is that these trials, if they do not represent real clinical practice, they have a very negative effect on individual patients. Thank you. Thank you.
Thank you all so much.
thank you. Join us. Right.